I too would like to acknowledge the traditional owners of the land. I'm calling in from the Wurundjeri, Wurrung and Boonwurrung lands of the Kulin Nation in inner West Melbourne. And I'd like to pay my respects to elders past, present and emerging, recognising that there's an ongoing connection to the land and that the land was never ceded. And I'd like to welcome any Aboriginal people who are joining us today. I'm starting with one of my favourite pictures, which is the ambulance of the bottom of the cliff. It's very old. It's been used as a metaphor for what we're doing both in public health as well as with prisons. And there's graphics in reference to prisons that we're effectively throwing money at prisons and we know that they don't work, which isn't necessarily a new idea or a new problem. And the same exists in health. We have very reactive, responsive systems that deal with the very late stage of problems. And that is one of the oldest problems in terms of how these systems function. How I'll go through today is I'll talk a little bit very briefly about my experience, because I think that's kind of the common thread of how will tell a bit of the story. I'll talk a bit about how I relearned a public health approach, and then emergency departments and our healthcare system in Australia and how we're doing. I'll then go through a few cases and my reflections from during COVID-19. So I went straight from school and I thought I was very open-minded and potentially public health and social-minded straight from school into medicine, and worked, always gunning to work in both emergency medicine and public health, but pretty much just in hospitals, which is really different to the public health landscape for most of the first 6-7 years of my training. After I did my general training, I hopped to Uganda where I worked and studied my Masters of Public Health. I then ended up working in the UK for a year, New Zealand for 18 months, and then in the Solomon Islands. And I say that because I got to see what were mostly emergency departments and trauma and orthopaedic departments in a hospital environment in a few different countries. And that will just come up later today as I talk about how we do compared to other countries in some ways. As I said, I thought I was very public health minded, but then during COVID, I started my actual public health training. And despite having the masters, I felt that I relearned and started questioning a lot of my perspectives that I developed as a clinician working in hospitals, where that you sort of get this culture and a very, very medical focus of what the purpose of health is and what's actually a health intervention and what's not. And so I kind of relearnt that. And then this year was my first foray into research. And I was lucky enough to start working with an evaluation and implementation science team, which were really into reflective practice. And so again, it was really reflecting on how the training we've had often colours our research or the academic work that we do, as well as, I guess, the focus of this research team is implementing stuff where it's evidence-based, but it hasn't yet just translated to policy on its own, and then evaluating why stuff works. And so that helped me sort of shape today's talk, which evolved into not just a systems talk, but how you take research to policy and policy to research. So it's meant to be the other way around. There was a talk by Karen Martin at the centre earlier this year, and I thought it was really great. She and a few other editors of the Lancet Global Health published a comment a few years ago and have published a bit of ongoing work around the research to policy sort of pipeline. And they feel that generally there isn't a knowledge gap, but often a translation deficit. Their suggestions for combating this, and they've written an article where there's a whole sort of list of reasons that there are barriers where things might fall down. Their suggestions are that you pursue relentless political advocacy, that you seek wide stakeholder input and you do that very early, and that you have an early plan for dissemination of your research findings. And I liked those ideas, but they were very high level. And I was left sitting there wondering, okay, but how in practice what are the skills? How do you do this? And I've heard Rob Moody, who also works at Melbourne Uni several times over the last few years with talks. He also runs a leadership course where he has reiterated a few lessons for how to be, I guess, a public health leader. His perspective is that when you want to affect change or affect policy, you have to tell a story. What you're actually trying to do to get people on board is you're building a narrative around what's happening and you're getting people engaged. You often need to, I mean, he accepts that you often have to learn from other stakeholders, and you have to bring together a really wide number of people. And what that often means is that you have to learn the language of other people. If you're talking to business and management leaders, you've got to learn economics, management. You've got to go and learn how other people and what their perspective is in different sectors, so that you can meet them at the table and try and come up with policy that is working in the right direction for all of you. In his leadership course, he asks you to reflect on your own and develop your own idea of leadership. But what he also talks about is servant leadership, which is really about acting for the good of others and thinking about what is to the benefit of others in all our actions. Leadership isn't necessarily authority. It doesn't mean that you're sitting in a position where you're making decisions. It's about maximising our own potential as individuals to lead and create change. And he also teaches that teams work, which comes from a myriad of Harvard Business Review articles where they, small management leadership teams work. If you want to generate ideas, you need a group optimally of 7, 8 or 9. And if you want decision making from that group, you want an odd number, not the 8. And so those ideas I've noticed that are sort of sitting at the top of my notes as I sort of think about public health policy now. As a very part-time researcher, he's probably a little bit more policy minded myself. I love these ideas of how we actually change practice or take research through to policy, because I don't think I've really understood it, and I'm not sure I do yet. This is one of the graphics that's relevant to health, but it's helped me understand that there are probably 2 pipelines. So from research, you can create evidence, which will change clinical guidelines directly, and that will change the practice of people on the ground. So when I work in emergency, I follow clinical guidelines. So I don't know what the policy that's coming through is. I follow the guidelines that are already there for everyone, and that's what actually how things operate on the ground with all the frontline services. That evidence can come through in respect to specific, so highly specific pieces of what you would do, but it's not normally that like systems overhaul. To get that systems overhaul or to change policy programs, to fund new initiatives, what you need to change is policy. Policy is effectively the government, and the government do what the people want. So what you have to do is invest quite a lot of time and energy into policy change mechanisms, which can be enhanced. And this refers back to Karen Martin's article in The Lancet, through early partnership between research and government or other policy, organisations or key stakeholders. And that's the way that we then change those clinical guidelines, or the way that organisations operate on the ground in larger ways. In the middle there in healthcare, there is quality and safety. And I think that probably refers to, and it probably exists in other systems as well, to some degrees, patient or people-orientated academic movements. So the human rights, the other drivers that kind of sit there that don't necessarily reflect full community perception and may not change government through policy due to overwhelming opinion, but do create change because they are drivers within that system itself. As I said, policy change still blows my mind a little bit. This is just a totally random from an article that's not even about health. It's about environmental governance, but it sort of looks a lot like the ones that I've been reading, or the sort of when in government blogs that I've been reading. You do have to tackle some of the challenges where they exist, and then it's a good idea to have an understanding of the enablers, because they're not actually as predictable as you want. As much as I'm saying or suggesting throughout this talk that you can affect change by changing the tide of public opinion, in reality, I think policy change sort of happens suddenly for what appears to be a window of opportunity and sometimes bizarre factors. But I put this up here because it strikes me that learning, having policy leaders and generating new ideas are really key, and they kind of go together. But I actually think the competing networks, the shocks and the window of opportunity are other drivers that actually work together. And one of the key lessons there is that shocks are not actually bad for change. They're not a barrier to change in systems. They're actually often a driver. And if shocks create competition, that is actually often a driver as well. And that's true in health policy. And I suspect it's true in other areas of policy as well. And so what it also makes me reflect is that the idea that we're looking at how emergency departments function in different states, and states that are getting it right versus states that are not, is actually probably potentially a driver for change, although it feels negative, difficult, challenging. In a lot of literature, competition actually often drives positive changes ultimately in the end. And that's true in a lot of health policy. So if we look at my first system under pressure, which is my original home, which is emergency departments, front page of the news frequently, in honesty, along with policing, prisons. You'll notice that the systems I'm focusing on today, including the mental health system, are frequently cited in royal commissions, along with the news, as well as productivity commission reports, which I think are probably really powerful agents for change at a political level and provide a window of opportunity. And there has been productivity commission reports on most of these systems in the last 5 to 6 years. But a focus on emergency departments. So over the last decade, and this is true globally, presentations have increased. They've increased well beyond population growth. They've increased in their diversity. All ages attend ED for a variety of reasons. There is nearly no country that has a huge package of alternative places to go for care. There are countries that do have alternatives to an ED for specific reasons, but by and large, ED is a one-stop shop for everyone's needs. However, I will say that most EDs, while there are ways of dealing with nearly all problems, including social presentations, aren't equipped with the full set of resources to deal with any presentation that comes in the door. About 10% of patients in ED will get critically unwell. And these are probably the focus primarily for ED doctors. Probably the key priority for ED doctors at the moment is access block. And what that means is that as a hospital gets full, and this is in part because of management theories where they've tried to reduce the beds of hospitals overall since the 90s, proportional to the population, because they want hospitals to run more efficiently. But as hospitals get full, which you'll notice happens during shocks, so something like COVID has obviously been a huge system challenge with reduced beds and reduced staffing. Victoria has the least of both in Australia. What happens as the hospital gets full is that for those patients that are arriving, once the hospital's at capacity and the ED is full, they have, I think, a 10 to 20% chance of a higher mortality throughout their stay. So proportionally, that gets quite high. And so ED doctors feel that a busy ED is not necessarily an unsafe one as long as the hospital is functioning. However, the public really hates crowding and really hates waiting, because most people in ED feel that their current problem is really serious for them while it's happening. The data on people who've experienced incarceration who also attend EDs that show that, like most people who are attending, who do just get discharged, they're attending appropriately. They have urgent problems that wouldn't necessarily be seen by a GP. And although they may not be admitted to hospital like other large portions of people attending ED, there isn't really, I think, data supporting the fact that it's inappropriate. In fact, most ED doctors feel that a lot of ED presentations are likely appropriate. However, there's a little bit of debate around what the long-term plan is to prevent presentations where people don't end up receiving any treatment or intervention or getting admitted. Of the people who experience incarceration, a lot of the data also shows that a reasonably large cohort of these are considered frequent attenders. which in the literature varies a little bit from whether this is 2, 3 or 4 times a year. Frequent attenders have been a target group for an ED policy for a long time. There isn't any emergency department that doesn't have a strategy. However, the strategy is funded pretty lean in most ED departments, in contrast to what most ED departments do, which is come up with a management plan and direct them towards the GP. St Vincent's in Melbourne has come up with a variety of different strategies that do include those management plans, but also include a cafe consultation for people who are presenting with mental health acute crisis who don't need admission. So instead of medicalising and then, I guess, perhaps minimising the presentation that they're coming in with, St Vincent's will take them to the cafe adjacent to the ED, which is also considered a clinical area, and conduct the consultation there over a coffee. It's very humanising. Amongst this cohort, the people who've come in for a mix of psychosocial stresses, so the mix of acute crisis due to job losses, homelessness, but in order to get a mental health admission, what you need to do is be genuinely high risk for suicide or harm to others, psychotic, and not wanting to go into hospital yourself. If you're help seeking, have insight, and would voluntarily go and get mental health help tomorrow if it was worse, it's actually normally standard that we try and manage those risks, de-escalate the situation, and discharge back to the community. What this study, which was done by St Vincent's, demonstrated is that for frequent attenders who do have problems, but they're not medical problems that require hospital admission, they get intensive case management. And what they found, which challenges the paradigm that I think most health departments and quite a lot of emergency doctors have, is that we want to reduce emergency presentations at all costs. This challenges that in that frequent attenders will have a bit of a curve where they'll increase their attendance to ED for a little while, and then it will drop off completely. And so what we see from this is that instead of having a frequent attender who's on a lifelong management plan, who comes in every few years, frequently in spurts, we'll see someone dramatically increase their attendance and engagement with a caseworker in the acute phase, and then actually develop a lasting relationship with providers in the community like a GP. And the way that that kind of works, and there's literature that shows similar in Canada, America, and lots of other places, is that it requires a really intensive effort to actually hand the relationship over to community providers. And that's for the cohort of people who are frequent attenders who, I mean, there isn't necessarily as much literature or research on why people are frequent attenders, but for whatever reason, they don't necessarily have established community supports, or they don't seek a community provider. They prefer the emergency department. And but there's evidence that there are ways to get people to kind of adjust their response to acute social stresses and gain skills to kind of help themselves in future that are more in line with people who are, I guess, thriving and who wouldn't necessarily frequently attend to the emergency department, where you don't always necessarily receive the right interventions. In terms of drug and alcohol presentations, they're really high. And again, they don't necessarily get any treatment. Admissions to hospital, this is core emergency department business. We see these people, we treat these people, and then they're discharged, and they're often not discharged to any service. Drug and alcohol services in most emergency departments that I've worked in are available some days from 9 till 4 p.m. And if the patient attends outside those hours, and you'll note that presentations increase to 1 in 3 or 4 on the weekends, then they won't necessarily get drug or alcohol counselling, even if they qualify for some sort of service. A sort of factor that's worth considering here as we look at some of the competing priorities with policy and staff in emergency departments is that drug and alcohol presentations everywhere in the world are associated with increased aggression and violence against staff. And in places where this is more extreme, this has become a really serious workforce issue for staff. In public health terms, alcohol contributes a very substantial amount to the overall burden of disease, particularly to brain health, both mental health as well as brain physical health and functioning over the life course. And it's obviously a huge driver of injuries. There are other studies that show that if we look at someone who's had a beer and injury, for instance, that the rate of alcohol-related presentations alone is actually around 25% in emergency departments. This statistics takes presentations that are coded as drug and alcohol when someone comes into the emergency department, but the actual alcohol contribution to emergency departments is really significant. Interestingly, when the Northern Territory introduced a minimum pricing of alcohol a few years ago, so what they did is that cask wine was effectively in some areas cheaper than milk to buy, and they created a minimum unit price for alcohol that made it a little bit less accessible. They did a sort of very extensive evaluation, which was kind of required with the legislation allowing the trial. They didn't find any difference in ED presentations. They just found a bizarre change. There was a weird number of increased, just a change in injury patterns. And they didn't find decreased mortality in things like road accidents. What they did find is that there was a decrease in low-speed car accidents that wouldn't have been flagged as being alcohol related. So obviously, if you're under 0.5, that's not an alcohol related car crash. But a lot of bingles on the road seem to have perhaps possibly been related to having a single beer and then driving home. There are a few other benefits to this increase in price that were not health related, but it's a really good example of where policy change within complex systems often has unintended consequences that can be both good and bad. And some of my favourite public health policy outcomes have been almost unintended or structurally designed to lead to an improvement like this, but had surprising results in terms of what the actual public health benefit was. Right. So the one point here is that, as I said, that alcohol is a real driver of injury and poor brain health. Health promotion, alcohol and other harm reduction strategies, as well as suicide prevention, all share the same risk and protective factors. So they're all actually amenable to the same early and preventative interventions in unison. And so when we look at funding each of these, if we're looking at funding these for multiple outcomes, we'll often be more effective in demonstrating that they are high value interventions rather than looking at one alone. In terms of mental health presentations to emergency department, these are about 3% of presentations to an emergency department in Australia. However, they are a large contributor to ED overcrowding. They're a cohort that wait longer than other patients for no good reason, who have a similar severity of physical illness before they can be assessed and have their treatment commenced. And one of those reasons might be that physical assessment areas are more available than private areas to conduct an interview for mental health. So by that, I mean there may be 6 or 7 beds to deal with fractures, minor finger injuries, whereas there might only be 1 or 2 private rooms to be used for family meetings or to have a private conversation about someone's mental health. They experience the longest wait times in the ED waiting for a mental health team. And if you look at the sort of times that's actually quite frequently 12, 24, or if you're talking about someone waiting for a bed in a mental health inpatient unit in an area that's really constrained, that extends to days, which is well beyond what any other patient cohort experience. They're more likely to leave the ED at their own risk after they've been initially seen for a little while, which is probably really related to the long times that they wait. We noticed that during COVID, when people started waiting longer, that a lot more people started leaving. Traditionally, less than 1% of patients leave emergency departments without completing all of their treatment in ED, but this increased during COVID and a large number of those were mental health presentations. It hasn't really been established properly because there isn't necessarily great data linkage, whether that came with an increased risk. So whether those people down the track weren't getting mental health interventions and whether there was any impact to mortality or other outcomes. If you look at the statistics for mental health in emergency departments, you'll see that young people are most commonly presenting, and Indigenous Australians are far disproportionately more likely to attend, as well as people in rural and remote areas. And there's a really clear socioeconomic gradient down the bottom in terms of the CEFA. So the first quintile are more likely to come presenting to the ED with mental health problems, which is really concerning now, I think, particularly with community access to low-cost mental health, which a lot of people might know that the number of sessions that you could access under a mental health care plan was temporarily increased during COVID due to the large number of COVID-related mental health presentations. And Nick, I didn't include it on these slides, but there's a pie chart of all of the people in COVID isolation attending the emergency department in hotel quarantine programs, not in Victoria, where they actually had COVID, but in Sydney and other states, and it was exclusively for mental health reasons. So anxiety, suicidality, the seclusion impacts of mental health impacts are really significant. I haven't touched on that, but I think actually that would be one of the key reasons for people to be transferred from prisons during or other incarceration sites during COVID-19 as well. So the total number of presentations is 280,000 in a year across Australia. And you can see from that graph that over the last 15 years, like all other presentations, that's proportionally increasing. I thought I'd just do a really quick mental health explainer. Mental health is kind of, very briefly, divided into 3 clusters in the sort of guidebook of diagnoses. There are and this is the personality types that doesn't lead to other. So there are other mental health clinicians, but the personality types are often precursors to schizophrenia or bipolar and other more significant mood disorders. But there's a cluster of traits that they're often referred to, which is probably quite horrible, as mad, bad, and sad. And I'll just say that to simplify it. But if you look on the left at the graph of mental health presentations from the Australian Institute of Health and Welfare, overwhelmingly, they are due to acute stress and somatoform disorders. And so what somatoform disorders are people having I guess like a trauma or stress response that comes out as a physical symptom. But would normally be quite evident to emergency doctors that it's not a physical symptom. A good example would be people who have non-epileptic seizures. So some people have wiring in their brain that causes them to have an epileptic seizure, and some people will have a seizure as potentially a trauma response. So the top 2 here are people who've had substance use and people who have acute stress. Underneath that, there are the formal higher grade sort of mental health disorders, so schizophrenia and disorders, a mental disorder that's not otherwise specified, which is probably non-specific and could include a number of things. Organic, so people who have an infection that might be driving it, is one of the lowest likely to be diagnosed, and mood disorders sit right there in the middle and include depression, anxiety, and bipolar. So now I'm going to hop to my reflections from working in COVID-19. So I started my public health training during COVID, but working in traditional health protection, so food safety and other areas. And when I came back from maternity leave, due to a kind of weird circumstances, I had been offered a job in emergency at one hospital 3 times and kept declining, but it's the nearest hospital to where I live. So I felt I had to take it, otherwise they'd never employ me again. But I'd also been offered my continuing role in public health. And so what I did was to work, despite knowing it was probably a bit much, half in each, which saw me working in an emergency department a few days a week, and then working in the COVID response a few days a week. Initially in the team that was managing vulnerable settings. So high-rise towers, social housing, disability, schools, all the settings that required a kind of nuanced response because they were for vulnerable groups, and it included prisons, but at this stage there'd been no cases in prison. And we had police custody. As we approached the Omicron wave, it became clear that nearly every setting needed nuanced and vulnerable advice, and that the supermarkets could all manage themselves. And it made a lot more sense for ambulance and fire brigade, emergency departments, police custody and prison to be managed together because of the large number of people who actually followed this transit pathway. and our team had expertise in kind of managing them across all the different systems, and then looking at them in different, providing a social response, potentially, rather than just managing the risk in volume. The other teams did volume and sort of, I guess, like aeroplanes and ships and things where they followed really strict protocols. And our team was kind of the experts in getting specialty social services involved. So if we needed to call mental health teams to a site, if we needed to get counsel to go help a family who are vulnerable, that was kind of our specialty. It became very obvious that there was very, very limited healthcare available in police custody, where people were clustered all together with a limited number of staff looking after them, which often prohibited their ability to even go to an emergency department or get healthcare. In Victoria, there was really only West Melbourne Police Station, which occasionally had a nurse, so there isn't access to healthcare very freely. And in order to manage staff, I guess people in prison custody tend to move a lot for whatever reason, and that's true pre-COVID as well. And the initial care in remand is nurse let alone. So there was limited access to healthcare for people who were often in a weird, sort of a mix of health states. And I guess what I know from emergency is that they're essentially attend emergency for any healthcare that they need, not any other. They don't access healthcare any other way as they transit through police custody. The number of people moving from the community through to remand since the 2018 bail law changes became really evident, or the impact of those bail law changes, and I'll talk about that when I go through some of the cases. One of the really interesting positives which was unique to Victoria, was the impact of Victorian emergency management days. So unique to Victorian legislation, they have a provision in their act that allows for a reduced sentence whenever they're in seclusion or lockdown, which I think is one of the, humane ways of managing the balance of seclusion and emergency management protocols in a prison compared to the other states. And that's very well received, reportedly, by both lawyers as well as people in prison in Victoria in comparison to other states. That would see a lot of sentences dramatically reduced during COVID, which it turned out was also really great for COVID risk. Less time in prison overall was great. The impact of that was that the cost of running prisons proportional to the service they were delivering, along with other COVID management, has increased dramatically beyond what was planned, which, again, we don't mind systems under pressure if we're looking for change. And so that is both a good and bad thing, but potentially an impetus for change. It became evident that frontline services are kind of fundamentally designed to work together. And although a lot of them have developed a narrow scope of practice, and it's taken a lot of time, energy and effort, for instance, to expand police skills to include health assessments, mental health, first aid advice, that they do actually have the ability to adapt. During the Omicron wave, the fire brigade went from their normal fire activities to 95% of the time assisting ambulance call-outs, and the highest call-out rates that they'd had for decades. And they were doing CPR refreshers and assisting ambulance officers. So the way that they can work together is certainly possible. There are some interesting interdependencies, such as, I guess, their vulnerabilities. The prisons and police force were both dependent on each other, obviously, in terms of their staffing. They needed the other system to be functioning, but the emergency plan for prisons, if they couldn't operate safely, is to call in the police, and the police didn't necessarily, I guess, have the staff to provide that if they were affected by the same COVID-related issues without placing the vulnerable cohort at risk. So the interdependencies and the shared vulnerabilities were able to drive a lot of those services to adapt and make changes that had previously not been possible. And then for the services that were unwilling to adapt or who were less flexible, those vulnerabilities became much clearer or impacted other services and actually had real impacts on mortality and outcomes during that period. So from sitting where I was, services that had contingencies and were ready to adjust were able to, I guess, make a much more positive impact on the community during that time. And that was most services in most ways. The population who have more frequent frontline services interactions, and that's all frontline services. So this is police, any community service, attending ED, so costing dollars in different areas of the system, are probably also much more likely to interact with either the justice or the protection system. And I mean more broadly, if you look at a social network of people who have any interaction with community services at all related to the justice system. So the people in the immediate families. There are a number of other really sad COVID impacts, such as a reasonable increase in non-accidental deaths in kids who had any prior interaction with the protection system during COVID. And so there was, like everything during COVID, a little bit of a mixed impact, but I feel that there's potentially a business case to be made around the fact that people are having these interactions and clear intervention points at different points in the system, at different points in their life, and that we're not necessarily taking all of those opportunities to provide interventions. There was another lesson that I learned from working in the hospitals, and this was for families in ICU who didn't accept or believe that COVID was anything other than a conspiracy. And the literature on that shows that often leads to complex or traumatic grief, so needs to be addressed. And in the discussions with these families who were not a minority, to be honest, there was a reasonable proportion of people who had some level of belief around this or questioning government. There was often a pattern of prior negative or traumatic interactions, not necessarily with the healthcare system, but with a government or social service, some level of Australasian, exclusion, trauma, and a level of distrust. And so I think public health systems are now starting to look at community trust and trust in services as a sort of key indicator of how some public health strategies will be effective. And vaccinations are a really good example there, where you see that really clear link between some sort of general trust in government and a public health intervention, as well as how you deliver that intervention. So it's important to realise that all of these negative interactions that you may have with a police officer or in a hospital have an impact for someone potentially across their entire life. So I'll now talk about 3 of the cases that I saw in my dual roles very quickly. I noticed I've got a few minutes. One was, this was a 34-year-old female during COVID while I was working in both roles, who called the police due to domestic violence. She was asking for help in front of the kids. When the police got there, they decided she was the problem, and they pulled her into the back of the divvy van, at which point she had a pseudo seizure, which would be a kind of mental health response to stress. While she had this pseudo seizure, her arm hit a police officer. So she was arrested for assault of a police officer. She came through ED, was COVID positive, which is how you sort of, some of these patients, I guess, flagged on both systems, because I then managed all these cases through the department and recognised this. But again, this is, and the point I wanted to make here is we provide no treatment or intervention. The healthcare system overall really doesn't provide any treatment for a non-epileptic seizure or this kind of mental health problem at all. But importantly, what's recognised in the literature is that there's a similar morbidity and mortality to epilepsy. So the outcomes for these people are pretty much the same, but we don't have a treatment pathway, because as doctors, we have this biomedical pathway where there's a drug or there's a clear treatment that we've proven in evidence, and social interventions, which might be what's required for a mental health version of the same presentation, we don't deliver, basically. The second case is really similar. Male found distressed and angry at the train station. Bystanders called police and ambulance. He sort of got both, because he was a mix of aggressive but crying. He reported that he was having home stress and just didn't want to go home. He became really frustrated. Both of these were my patients. In this instance, I felt there was likely to be something that did warrant mental health intervention behind this distress. So rather than just discharging him, I was quite invasive. He felt the questioning was really invasive, and so he punched a wall, which I felt I had driven by my questioning. At this point, the police, who were already pretty annoyed at him, were thrilled and arrested him for damage to property. I'm pretty sure for him, this was his first interaction with police ever. He wasn't known to police at all before this. I'm not suggesting that going to prison is a bad response to what could be family violence or stress at home, but in both of these instances, I feel people were arrested without getting any other intervention at all. He also entered remand, which means he went through prison in the next 24 hours, COVID positive. The third case happened during COVID as well and was not my case, fortunately, but it was another really sad case. That sort of makes me think of this intersect and the lessons we can learn by actually following people through their systems, because what was evident is that there isn't normally a pathway or a transit. These systems, police, ambulance, work very separately, and while there is data linkage between ambulance and EDs, that's still in its early stages. We don't have a great idea of the number of people who go through this whole pathway and why, because these systems don't work together, and a lot of these agencies, such as police, for instance, are not in the short term likely to get a technology system that allows them to link and do that easily, or to manage health problems. So they're not going to get an EMR, a medical record system, in the short term. This coroner's case, I'll link this if anyone would like the slides later, was a 30-year-old male who'd had bipolar disease due to an initial episode of psychosis while he'd been taking marijuana since 2014. He'd historically ceased treatment, so he'd be under an order for a while, and then after he was appropriately managed, he'd stop engaging. In early July 2020, friends and family referred him multiple times to his old mental health service. He himself was really health seeking. He wanted help. He was trying to call the service regularly. They declined his referral a few times, even though they couldn't get in contact with him. Community services were involved and had decided the family were causing conflict, and if they lived separately, it would probably be fine. But they didn't identify that there was a risk that he was having thoughts of harm of his brother, although friends had tried to report this to other services. So lots of people had bits of information, but the information wasn't shared between services throughout the few weeks that this was building up. He attended hospital to see a psychiatrist. However, he was turned away because he didn't have an appointment. He was turned away by staff at the front who didn't actually have that authority. But it was also clear from the mental health services several days that they hadn't really gone to the effort of making the appointments with him in the community. On the 15th, finally, after everyone's attempts, including his own presentations and calls to the service, several of these, he broke into the home of his family where his brother, he'd been having these thoughts of harming his brother. There was an altercation where he tried to stab his brother and harmed the rest of his family. He was clearly in a fairly decent psychosis, but he'd been having these thoughts for a while. He was brought in by police under a section 351, which is where people are brought in for assessment by police, which is really frequent, really mixed, sometimes for very good reasons. There's a lot of debate where some people feel these are done too frequently. They're probably not done often enough in some instances. I think mental health patients still fall into a category for EDs where they're just not adequately resourced to deal with them. The Victorian police team changed over, and so they didn't have the whole story. And so the handover to the staff was really just that there was an altercation. There was the very standard long wait to be seen by someone with a mental health presentation. The specialist mental health team in the emergency department had seen some of his files and thought he should be assessed, but they didn't go see him themselves, and they didn't talk to the doctor. The doctor who saw him briefly, because they're very busy, decided that he wasn't eligible for an assessment order, which is where you keep them there and have them seen by a specialist team. Because he was help seeking, he was open about his mental health, and he was happy to go seek help from the community teams like he'd done the day before. The story wasn't double checked with anyone else, but this is probably not uncommon if you can't easily contact others and the police don't provide the contact details and the patient doesn't provide them either. He didn't get any mental health team follow-up as would have been planned before the 17th when he called his mother to a park and began stabbing her with a stick. He was then shot by Victorian police 17 minutes later and died. The mother survived after resuscitation, but has a lifelong brain injury. So I just thought I'd add in here police shootings, just because it's related to the relationship that I guess the community feel that they have with police, and then indirectly with emergency health providers who do have a relationship with the police. They attend ED oftenly, and over the 10 years I've been working in EDs, I've seen that relationship change and work differently in different countries and also over time. A lot of the key factors behind police shootings and mental health hasn't been treated. Not all of them are probably avoidable, but there's often a factor where there's an issue with aggression with police, potentially due to prior experiences. And what's often cited is that there's a lack of tasers, which would be obviously a safer alternative in some instances where they're deemed safe for use. Australia doesn't do too bad overall for police shootings compared to a lot of other countries, including Sweden, which we often cite as having one of the better healthcare systems and social systems. But I'm now very interested in what Denmark and Iceland are doing in terms of their policing strategies. I think this is probably a little bit, I'll try and be super fast here, related to restrictive practices, which are a very hot topic now. Every state and territory is aiming for zero restraint at all, particularly in any mental health setting. This has been a really sudden change, particularly in Western Australia, where a man was charged with assaulting hospital staff after they tried to keep him from going, but he was found not guilty because the judge thought it was unlawful to have restrained him, even though he was not considered medically safe for discharge. And there's a lot of complexity around the laws that apply here that are different in every country, and ways of getting stuck. If someone is under the influence, has a mental health issue, potentially a medical problem, they're in a bit of a legal tricky spot, and it differs in different jurisdictions how that can be managed. Most patients in ED are actually not mental health patients when they're sedated. It's often for behavioural reasons, and they're often people coming in under the drugs, influence of drugs and alcohol, and they're often people who have lifelong behavioural issues. They are often the people who might have experienced incarceration or have these troubled relationships with authority, and that drives the behaviour. Our rates of restraint are a lot lower than a lot of other countries, such as the US. But they're also a lot higher than New Zealand, where peer-led mental health services are more common. And that's despite a much higher rate of methamphetamine use and presentations to emergency in New Zealand EDs. A reflection here that I'm not qualified to comment on is that New Zealand appear to have different policing policy and practice in the community, and that a different relationship with ED staff and different attendance within the ED. In contrast, all prisoners attending a hospital or emergency department in most countries are often shackled to the bed, multiple arms, the entire time, including during treatment that might be painful. So one of the sort of potential, I think, agents of change might be with this huge drive to reduce restraint for all patients, is that we can point to the disparities for people who are prisoners who are coming into hospitals for care at the same time. In the interest of time, I might skip this, but I do think there's a little bit of an interesting intersect here with sort of neurodiversity, and a few studies that show that people who have ADHD tend to be overrepresented, as well as under-recognised in interactions with frontline services, ED attendants, as well as experiencing incarceration. And so finally, I'll leave it on this comment that research is formalised curiosity. It's poking and prying with a purpose, and that I want us all to think about the purpose of what we're doing when we do each piece of research and where we might be going.
Thanks very much, Caitlin, for a really thought-provoking presentation. I love that quote to end on as well. You've got me thinking in a whole bunch of different directions, and I really appreciated that thread of mental health and kind of thinking about those sort of social and interpersonal factors, as well as the system factors in managing and supporting people with complex needs going through these systems. We do have about 5 minutes for questions or comments, and I'll invite anybody who wants to ask a question or comment to just unmute yourselves and go for it. Lindsay, looks like you're first.
Okay, hopefully this works. Hold on one moment.
Yeah, I can hear you.
I decided to take my headphones out because I could hear myself speaking through this at a different time. I'll keep it really brief. I'm just wondering, Caitlin, do you think things are getting better? Obviously, COVID really exposed in a lot of systems where things were not working adequately. And I think that was really evident in the prison system, and it seemed very evident in a lot of the case studies that you were looking at. Do you think we've learned anything, and has there been any applications to change and improve how we manage people with complex health and justice experiences from a health perspective?
I mean, I don't necessarily think so right now. I think there's a few promising signs of change that are also sort of happening, such as the decriminalisation of public intoxication, which is now a public health-led response. But I guess one of the issues with that is, in terms of a change, that change in legislation was great, but compared to other changes in legislation, it wasn't resourced with any particular system. And it's not necessarily as a public health response to someone who's drinking in public to bring them to an emergency department too. That's a responsive system. That's not a prevention system. That's not looking at the underlying drivers. If someone has, what might be a mental health or just probably acute crisis underlying that, and the healthcare system is still really focused on biomedical interventions and the mental health system as well. And so I'm going to actually freely admit this wasn't actually, because I went for way too long, the end of it. But what I did have here was a sort of slide, which is a sort of just mess of ideas, which is that we kind of need to bring all these reforms that I think are happening. So there are mental health reforms underway. I think there are significant calls for justice health reform that at some justice system reform, that at some point are likely to probably create some degree of change, if not reform, and that they need to kind of be integrated, and that we need to look at how all these systems are really interdependent on each other. And if you're looking to save money in every system on exclusion, that what you're leading to is greater overall costs, and that we need to have that outcome focus that public health has. And so I like the idea of having a public health approach. But I think one of the challenges is that maybe it's at a government level, they need to realise that they need to resource that public health response. So when the CDC talk about how they operate, they have sort of like 10 essential public health responsibilities, and only a few of them are kind of what we think public health teams do in government. And the other ones are like policy and evidence building, communicating to communities. And so those parts of a public health response really need to be resourced to actually create that change. I think that there are other challenges, and Karen spoke about this in her barriers to change, such as implementation or scaling, stuff that isn't designed to. But I think fundamentally workforce can often adapt, and that I've written here also as well, I feel like everyone is going to need to be not necessarily a mental health expert, but someone's in crisis, I can help them to some degree, and a mental health advocate, so an advocate for better mental health systems that are accessible for everyone. And I think that for all frontline services, I think that the fire brigade have adapted to CPR, and that all disasters are fundamentally a mental health disaster as well. And we're starting to understand that when we talk about disasters. So if you talk about like an earthquake overseas, disaster practitioners will definitely talk about how that's also a mental health disaster. But we kind of need to get used to the understanding that if we're talking about something like COVID here, even if there isn't a mass suicide, it's still a mental health challenge or a disaster. And when people are experiencing an acute mental health crisis for themselves and their world, their job, their housing security, it's starting to fall apart for them, that is kind of a disaster for them. And they kind of need some sort of system and response to that. That's not just a plug the hole response, that how do we actually avoid this happening for people in the first place, and then avoid the impact to their family. The kind of public health idea here is that the determinants of health and the sort of intersectionality. So I really like the idea that all of the vulnerabilities, so the people who have intersecting needs, because we have systems that just deliver a service the same to everyone. They have these intersecting needs that mean they're really vulnerable, and they experience compound disadvantage. So when they don't get a service because they might be deaf, but they also can't easily get there because they don't have a car, so they go out of their way to drive there, but then we're like, no, we can't do Auslan, we can only do phone translation or something, that they experience that compound disadvantage because systems won't adapt to make sure that everyone can get the same outcome. And we need every system, whether it's police, health, justice, to be orientated towards achieving equity of outcomes. 50% of health outcomes have nothing to do with the healthcare system. So they're purely social. They're other factors. They're your education system, your ability to have a job and pay for food and water that's clean. And that's true in all countries. So we kind of need all of these systems functioning and working for everyone and considering equity, where we're only as strong as the weakest link there. If we have some services that are really letting us down in terms of the equity they deliver, then we're not going to see health outcomes change. We're not going to see outcomes change in the justice system.
Okay, look, thank you.
Yeah, sorry.
Thanks so much. You articulated some of those ideas so well, and I feel like we could all happily keep on discussing this for a while, but I am mindful of time, and I might just perhaps invite if there's one more burning comment or question, if anybody had something they wanted to add before we finish up. I see you getting lots of congratulations in the chat, Caitlin, so I'm clearly not the only person who really enjoyed your presentation.
Stuart, it's Nick. Can
Yep.
I make a quick comment?
Yep.
I worked for 6 years in Amsterdam, and I worked with the Dutch police, and a lasting memory is the fact that every year the budget came around, the police were very vocal about the need for increased funding, not for themselves, but for the mental health system, because they recognised the better the mental health system, the easier their job. So finding that sort of, I mean, what Caitlin has said is just so articulate, and you've just put it so well, Caitlin, but finding those sort of cross-sectoral common interests, I think, is a really essential part of the exercise.
Yeah, and that takes time to build, I'm sure, Nick.
We need a global law enforcement and public health initiative of some sort, Nick, to do that. What
a thoughtful idea. I'm going to grab the moment. I hope everyone's aware of the Trauma-Informed Policing Conference that we're running next February. And if they're not, I'm very happy to send around information about it.
Yep. Look, Nick, if you can send it around again, we're Claire, I'm sure you wouldn't mind sending a link to it again. It sounds like it's going to be a terrific meeting, so very happy to circulate that around. Yep. Look, I am mindful that we're over time, Caitlin. Look, I've really enjoyed this presentation. It's been a fantastic way to cap off our year of webinars. And once again, thank you so very much. Just before we finish, I will remind everybody that we'll be kicking off this webinar series again in February of next year. We're putting together a calendar, and we've got some fantastic speakers already lined up for next year. If you're not on the mailing list and would like to be made aware of these webinars, please shoot an email to myself or Claire Chiminello. We're happy to add you to the email invitations. We won't bombard you with stuff. But it'd be great to have this network grow over time. That's it for now, though, but please just join me in thanking Caitlin for a fantastic presentation. Weird Zoom clap. And Merry Christmas, everyone. We'll look forward to seeing you in this same Zoom room next year.